Welcome back to the show. Today's episode is a very special one. I'm joined by Stuart McDonald, who is a very experienced practitioner and educator, and he has been working behind the scenes to bring you the brand new Working with Trauma and Women's Health program. This is going to be launching very soon, and I'm very excited to share it with you. But this program has been a really long time coming. We actually created it because so many women's health issues that we see come with a history of trauma, at least, whether it's birth trauma, whether it's medical trauma and gaslighting, past abuse, or even things that are more subtle, like cumulative experiences that live in the body over time. And yet, most of us were never actually trained to recognize or work with those layers of complexity in a confident way, especially in clinical practice. So, Stuart brings a very, very powerful mix of lived experience, clinical wisdom, and also like clarity. A lot of clarity in this topic, especially when it comes to our scope of practice. So, in this episode, we'll unpack why this work matters, what trauma actually looks like in the body, and how we as exercise professionals have a very, very important part of someone's recovery without stepping outside of our scope, obviously. Now, whether you are already working with clients affected by trauma or you're curious but cautious, maybe, this conversation is definitely for you. And if you are interested in this up and coming program, this will give you so much clarity about what we're covering and how important this is in regard to your work as a clinician. So let's dive in. Hello, Stuart. How are you?
Hey Courtney, how you doing? Good to see you.
Good, 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 good. Welcome to the show. It's lovely to
Thanks for
have you
having me.
on.
Yeah, it's good. It's great to be here. I'm stoked. Yeah.
It's such an exciting time with your program coming up. So we're going to talk all about that today. But for everyone listening, let's just give the listeners an idea about who you are. So introduce yourself, Stu.
Oh, thanks. Uh,
You're welcome.
I'm Stuart McDonald. I'm an exercise physiologist. I've been in the industry since the 1990s. I started life as a personal trainer. And at that time, I was studying a psych degree and I wanted to become a psychologist. And I'd also had a human biology degree, so in anatomy and physiology, that was my degree. And then I was doing a psychology degree, and I thought, yeah, I'll become a psychologist. And I ended up needing to pay my way through that. And so I thought, wow, I'll become a personal trainer so I don't lose all my anatomy and physiology stuff. And I just became I fell in love with corrective exercise actually with
Yeah, right.
that kind of stuff. Yeah, yeah, yeah. So I ended up kind of going down that route instead of I finished my first degree and I ended up not doing the psychology masters and stuff at that point, and I got into all the corrective stuff. But what I was working on was it was my body. That's kind of what got me into it because I was experiencing all this irritability and agitation in my body that no one could really explain, and a whole bunch of symptoms and stuff going on. And my sports medicine doctor eventually did some investigations and found some cool stuff. And he actually said to me, he said, don't tell any other doctor I'm treating you this way. They'll think I'm a quack because it was all this research coming out of Europe at the time that definitely wasn't normal over here. And then I had to rehabilitate. So that was all hip based stuff. I had stuff done in my hip and I had labral tear and had a bunch of other stuff going on with size major and a whole bunch of sympathetic stuff in my body. And the rehab for that got me down a pathway of thinking, wow, I think there's a stronger connection between the body and our emotions than we've ever realized or we've ever thought. And all of this irritability and agitation, a whole bunch of stuff, all this anxiety kind of stuff, but I wasn't having anxiety thinking in my brain. It was really weird. So I started using the physical stuff to heal myself, and I had to seek out other people to help me with that. And then I started attracting other clients with those kind of symptoms. And it
Mm.
snowballed from there. And I started putting two and two together that someone with these kind of symptoms and someone with anxiety, wow, there's a connection here. And then from anxiety, it's not a very far leap to go into your trauma stuff.
Yeah, right.
And
It's
that's
very
that's
closely
kind of
linked,
where it
isn't
went.
it?
Oh, it's amazing link. Yeah,
Mm.
yeah. As you look at the research, the literature, you find there's more of that in there. Anyway, so that was where I began clinically, and then got into my Pilates work and my stretch therapy work. And I actually have I have a routine of stretching and breath work that helps me manage my own stuff. And I got chronic fatigue syndrome when I was doing my master's in clinical exercise physiology, and that was really stress related, massive stress and massive trauma. So my family went through a whole bunch of stuff all at the same time, uh, and and trying to run a business and then not being able to give up the lease for my old clinic, and we were paying off the equivalent of two mortgages while we had three kids under three, and then I had to go back to
Mm.
extra study, and a whole bunch of stuff happened, and then there was a whole bunch of layers of emotional stuff in my family, and so my body just went to poo. Uh,
Yeah,
excuse
right.
me.
Okay.
Am I allowed to say that? And so I had to find a new way of practicing, right? Because I was running Pilates and stretch and personal training clients all the time, and I couldn't do it all of a sudden. And and it was really, but I still had to make money and I still had to be a professional. And so I got really interested in chronic pain through my experience and through my clients' experiences. And again, the link between chronic pain and trauma is really close. It's not, they're not the same, but there's a lot of similarity. And so I ended up finding another professional who was near the end of his career, a psychologist who'd done lots of somatic work with people with pain and trauma. And so I started talking with him. I said, "Look, hey," he spoke at a conference I was speaking at, and and I said to him, "Look, can I catch up?" And it turns out his clinic was diagonally across the road from my studio, and we didn't even know from my
Yeah,
Pilates
wow.
class. So I would see him every week, and I would debrief with him on the complex clients. And most of my clients were women because I did mums and bubs work, right? So I did heaps of prenatal and postnatal work with mums, so lots of pelvic floor hormonal stuff, and
Yeah.
them
Yep.
to recover through that. And that was the majority of my client base. Anywhere from pre prenatal to postnatal. So we do a big chunk of them, or the people who had the babies 15 years ago and they never addressed the issues in their body. Uh,
Yep.
and so that was kind of the bulk of my clientele. So I was doing lots of debriefing with Peter Thornycroft, that is. He was amazing, and talking with him about a lot of that stuff. And turns out that what he was trained in and was mentoring me in was what we call ontological coaching, which is embedded in from Maturana and Varela. So these Chilean philosophers who are kind of the spearheading biologists and philosophers in what's called enactivism, which is looking at a different model of how we think of the person embodied. And so that's really molded my way of thinking. And then in later years, I got into, as I developed more trauma work and started working with really complex clients, then there becomes a big overlap between the chronic fatigue and the dysautonomia that I work in and the trauma stuff. And now we have these three domains: chronic pain, trauma, and your dysautonomia, that have kind of bundled together in my clinical space. And I've had to find the connections physiologically for them. And it turns out that as I researched the literature, where they led me to was where I was being mentored for years in the ontological coaching into enactivism. There's been this big loop of, wow, like I've been really privileged to be taught this stuff. And now I'm seeing how this is actually being used clinically. So I ended up having, there was nothing in Australia. Like there was nothing here that was targeting that level of stuff. I ended up having to go to Europe to the inaugural enactive trauma therapy conference because it just fits so perfectly with exercise physiology. And what exercise physiology does is it bridges the gap between injury, pain, trauma, and your therapy you get with your psychologist and your counselor. There's this little gap in there. And EP is like just slots right in to that
Yeah.
gap.
That is so exciting. And I think we're going to dive a little bit more into that because I think this is where people are a bit confused about scope of practice. But
Yes.
which I think is a big topic that we need to cover.
We have a whole module covered on that in the
Yeah,
course.
it's true. We do.
Half a module's
Yeah.
dedicated. Yeah.
And this is actually, I want to talk about this little point that just came to my mind because I know there's people listening that are probably like just mind blown already. But I actually met Stu through work. I worked briefly with you as a colleague, and
Yeah.
Stu used to have all of the really complex clients that I was just like, I don't even know how you're helping these people. Like, honestly, if he was sick, there's no way I'm taking those clients because I had no idea what to do. I didn't know what we could do, in a
Yeah,
sense
right.
of EP at all, and it was just beyond my understanding of what our job was, and our role was within clinical care for those populations. But for me also, I'm hearing a lot, everything that you talk about, like trauma, the chronic pain, and then all of those other sort of what was your other population?
Dysautonomias.
Autonomia. That's right. I always get confused with that word.
What
um,
is that word?
I like dis something. Yes. um, I feel like a lot of it just bridges into this gap of like just mental health and the struggles of a lot of things in life, really.
Yeah.
So I want to talk about that because I feel like the content that you're going to cover
Mm.
could could really cover a lot of populations. It's not
Yeah.
like we've designed this program around women's health specifically because that's where I fit in and what I really see a big gap in. But
Mm.
the concepts, I believe, could be transferred to pretty much any
Ah,
population where the person has,
psychosocial. If you've got psychosocial
yeah,
disability, if and who doesn't have some kind of psychosocial uh,
yeah,
aspect to who they are. We scope of practice, we look at a biopsychosocial approach. So that's meant to be as an EP, that's what we're supposed to do, right? Biopsychosocial. We're
mm,
supposed to be having that approach. So if it's applicable over here, then there are elements of it that have to be applicable over there. And so if you think of it in terms of psychosocial concerns, that's going to make a big difference to your understanding of what we're doing. It's
yeah,
not, it's not trauma, it's not women's health alone. It's the ideas that apply in this context that have to be nuanced and tweaked when you're doing exercise prescription and stuff like that. That there's elements that have to be specific to a population, but we're all humans
mm,
and we all are impacted through these things emotionally.
yeah,
Yeah.
100%. And one thing that I think we've already talked about this off the recording, but when you described to me what the course was. It was, you actually said, I'm going to read this. It is trauma informed course, but it's not a course that teaches you how to be trauma informed.
Mm.
Rather, it teaches you how to apply the principles of exercise physiology in ways that can help the person with trauma and women's health conditions or concerns strengthen their recovery. So, can we talk a little bit about the work that you do in a sense of the trauma care, not trauma informed, but like going deeper into it, because that's what you're going to be teaching essentially.
Yeah, absolutely. Absolutely. So I believe really firmly that exercise physiologists are probably the best equipped or can be the best equipped people to start dealing with this kind of trauma stuff. I believe that we need to have really strong relationships with psychologists and psychiatrists. I think that it should be part of our professional upbringing if we're going to be working in these populations. So um, to a large extent, what we're taught about working with trauma or PTSD clients is this: exercise is good for trauma. Put them into an exercise group 3 times a week, they will get better. So, case in point in my brain is a DV client. Now, unfortunately, there's political and philosophical concerns there, but we'll get them for 20 to 30 minutes. You do your exercise, you leave. That's the extent of what we're doing. That's fine. The only problem is we're equipped with far more knowledge than that. So we know as exercise physiologists about the sympathetic and parasympathetic system. We understand about that. We understand, or at least we were taught it in first year,
Yeah, a while
but we
ago.
have the capacity to understand it again. And so if we're thinking about someone who's doing exercise, we know that the sympathetic tone is going to be increased significantly. If all we're doing is giving them exercise, that's fine if you're in an isolated laboratory environment. But what about all the other stuff of life? So you've got trauma, all of a sudden you can't work, you're trying to manage a family, you're getting fatigued. What's going on there? Why am I so fatigued? I can't function all the time. I'm tired, I'm sleepy, I can't concentrate, my memory's lapsing. This means I can't be going to work. Oh my gosh, I go to work, I get triggered. Now what's happening is I'm generalizing out the symptoms. Oh my gosh, even when I just go to open up the car door, I start getting heart palpitations and I start dissociating and having this horrible trauma response. And all I'm doing is hopping in the car to go to work. All of these things are happening. Then we take them to the gym, we put them on the treadmill, we put them in front of the weights. And what are we doing there? We're increasing their sympathetic drive even further. So all of those events are increased sympathetic drive. Now we're increasing their sympathetic drive even further, which means we're exacerbating their symptoms. Now, over time, it might help and get better. But for the acute cases, it can be really, really, really dangerous. And we can actually be creating things that are worse for them. And how I got to here is I would get psychologists. Unfortunately, I would get psychologists and doctors, GPs, telling people to go and do XYZ exercise. It's the same with the chronic fatigue stuff. But I get them saying, this is good for you, go and do it. And they go and do it, and they wouldn't get better, or they get worse. Usually they would just not get better. And I started to think, what's going on here? This shouldn't happen. We know that exercise is good for people. And so as you start listening to the stories that people bring, you start seeing themes. And so as far as being an EP treating someone, the kind of skills that we'll be covering are, how do we do that? How do we listen to a person's narrative? And I've got a tool that I've developed that we use called the salience and valence
That's good.
tool. So we actually assess the narrative in their body as well as in their words. So it's not just a talk-based therapy, but we're assessing the whole person. And where this is embedded in is the biology and the physiology of emotion. So I've done master's research into that and written a project on how our body constructs emotion. And you have to come to what emotion is with a certain definition. And I unpack that definition in the course. But basically, that emotion is the will to act in our body. And so this means that if you're having some kind of emotional experience like anxiety and trauma stuff, then exercise physiologist is almost the only person qualified to deal with it, because we are trained to understand how the body is changed physiologically through exercise. And if your emotions manifest through your body, if how you feel and what you think and experience happens with your body, and if we can modify what's happening in your body to change those emotions, then who is most suited to do that except someone who's working with a person's body all day, every day,
Yeah.
helping them change its physiology? Hello, that's what we do. And our scope of practice says we're involved with behavioral management and helping people change their behavior from here to here. That's what we're trained to do. Or if we're not trained to do it, it's in our scope of practice, and we should be trained, and they should come and do a course like this to learn some tools to help them.
100%. I love that. That I think that really helps define the scope of practice in the space, right?
Yeah, right. Absolutely.
Yeah.
We have these statements and these words about scope of practice and professional practice, but do we really unpack what they mean? It doesn't mean doing your bloomin' what's it called? The When you set goals, I can't even remember it. I've dissociated it from
Goals.
my brain. But we say this is you should make your goals. They should be smart.
Smart goals? Was it smart goals?
Yeah, yeah, yeah. And there's even some literature around its inefficiency for complex clients now. There should be smart goals. And when we look at the literature, we've got people like uh, Fried, Eco Fried, I think it is, over in Europe. He's looking at mental health disorders. His focus is more depression, but he's looking at mental health complexity, that we're complex systems that get perturbed, and it's not as simple as you've just got to do this, and that, because with a complex system, when you trigger into complexity, we don't cover this in as much detail as I'd like in this course, but I've got other courses planned in the future for this.
2.0 coming.
Yeah, that's right. But when we look at them as a complex system, so a bike is a simple system, right? If something's wrong with a bike, I look at the chain, I replace the chain, it's fixed. But a human is a complex system. With a human, something goes wrong. If I replace that thing, I don't suddenly get better. If I did, then all
Mm.
the medications would always work all the time for every person, right? Because we found the thing. And that's what we call the reductionist approach. We're trying to reduce the problem down to individual things. But I'm definitely not a reductionist for this kind of stuff. With complexity, that's not the case. We have to find all the different handles to create the new normal and generate a new steady state of well-being, help the person do that. Now, exercise is a dynamical process. We talk about homeostasis in the body. This is the dynamical processes, these things that change over time. That's what homeostasis is. That's what we're dealing with. The heart is dynamical. The circulatory is constantly moving. Vessels are opening and closing all the time. Muscles are contracting and relaxing. Some are tight, some are not. All this stuff's going on and it's working in synergy. This is the domain of exercise physiology. And this is dynamical and therefore it's complexity. And so we are absolutely 100% suited to that. And these are the kind of things that we'll be exploring to work out how do we manipulate these events in the interaction we have with our clients? How does the knowledge we already have apply to these clients? And how can we think of that in new ways? So that we can take what we already know, all these tools that you've already got, and apply them in a new way to this context. It's really exciting and it equips you to think differently, to approach the body through just a little bit of a different lens, which you can then start to see, wow, I can apply this to anyone.
Yeah.
Thinking about women's health, though, think about how complicated that is. Yeah, okay, you're coming to me and you're having period issues, but you've got weight issues, and I've been exercising for 10 years and I've been dieting right and it's not making a difference, and I've got this weird pain in my back and it's running down, and what's going on, and I don't really feel like being intimate with my partner now. And so we're starting to say, well, what's going on here? Oh my gosh, I'm 45. Are you perimenopausal? Well, yeah, I'm on HRT. It's kind of helping a little bit, but there's still other stuff. Well, what's going on? Let's have a look at you as a complex human,
Yeah.
understand the emotions that are driving you and biologically why they're driving you. And then let's find how we can tweak that in a way that changes, that's meaningful for you.
Mm. I think even just hearing you talk about like the emotions, how you talk a lot about that in a sense of
Yeah.
the work that you do. And when we think about the changes that women go through just in their hormonal changes through life, pregnancy, postnatal changes, perimenopause, menopause, the emotional side that just comes with all of that, that affects them in so many different ways. I feel like this work would even just support that.
Absolutely, absolutely. Um, because what we explore is what an emotion and a feeling is biologically.
Mm,
What does the literature say about the current literature say about that? And a lot of people will take a kind of a cognitive behavioral therapy approach, but that actually is embedded in one model of what emotion is. And there are multiple models of what emotion is. And the neuroscience literature, I would argue, um, suggests a constructivist approach more than an appraisal approach where we appraise what they are. But all approaches, when you look at the review of the literature, use bits of each other now. And unfortunately, the tools that we're taught are embedded in an old way of thinking about what an emotion is, and they're not really bringing across what the literature shows us.
mm,
Having said that, I'm of a firm belief an emotion is an action program in the body, that it's a biological reality, that we construct emotions from our physiology, and then there's stuff that where we can reconstruct or reenact our experiences and recreate the emotion in our body using our mind without having to be in the thing that originally made the change. But there was an original context where our body responded in a particular way, and and if we can help the person's body to shift itself naturally, physiologically, then they'll shift their emotions. So all of those feelings that these women are having with their concerns, they're real, and we need to validate those emotions. And in my experience, well, if we know the literature, we know that women most often, more often than men, are gaslit. That's just a thing that happens, right? They are told that they don't have these issues. Now, if they have complex issues, we know that complex issues are gaslit more often than simple issues. And I can tell you stories about that. Uh, Many, well, you can too. You're in the same kind of region as me, but there are some horrific stories of people being gaslit, being told that we don't want to see you because you're too complex. You're not welcome at our medical clinic because you're too complex. I mean, that's devastating. So
yeah.
if you've got a complex medical condition and you've got trauma, these women's health issues, trauma, these are two very complex things. And you're a woman, so now you've got this trinity of gaslighting going on. So now you've got medical trauma and emotion. And the first step as a professional is to validate their experience, to say, yeah, what you're experiencing, what you're feeling is absolutely valid. And maybe even say, you should be feeling something like that. Or maybe say, I'm not surprised that you feel that way. But a lot of the time, professionals don't feel safe engaging emotions. And what I want to do with this course is unpack, well, you know what? We can.
Mm.
Because an emotion is simply the body's way of manifesting whatever's going on in it.
Yeah.
And and I unpack a different definition. Emotions and feelings are not the same. And we talk about what that is. Yeah.
It looks very cool. I'm so excited to share this one when I see
Oh,
all the content.
you've been
I
looking at
feel
the
like
outlines and putting it
there's
together.
yeah, I've seen all the like the outline, but not the in-depth. So I'm really excited too. But I think that kind of bridges in really well with um the common belief that trauma is stored in the body.
Ha! Well, that's a question.
I feel
Um,
like you just answered it by your response.
this
Um,
comes from a really noble place, right? Yeah, yeah. Sorry, you were
let's talk
saying.
about this.
Let's unpack this a little bit.
Yeah.
Trauma stored in the body. What a beautiful statement. Yeah, that's a really helpful way of looking at what's going on because people tend to ignore their body, right? And they need to use their body to get it out. But I don't like it. And I'm going up against
Funny.
a lot of big names in the industry when I say it,
Mm,
in the trauma treatment industry when I say this, right? This is confrontational stuff. But nothing said without a reason. So the reason I'm hesitant to use this phrase is the reason I'm hesitant to use a lot of phrases. Our language is really important. We language the world we live in. We create meaning. We bring forth the world using our actions, and words are a means of acting. So when I speak, I'm creating a reality for myself. It's really complicated and active kind of ideas, which we unpack a little bit of that in the course. But when I speak, I'm creating a reality as well as speaking forth the reality I believe to be. So my words, my language, my story creates a certain story. So trauma is held in the body. That implies to me that it's a bad thing and we have to get it out of the body.
mm,
Right. So trauma is stored in my body. Oh no, the reason it's stored there is because you haven't released it. And I see this on Instagram all the time, especially it's rife with people talking about it. Now, this is really helpful. A lot of people get liberated. And the reason for that is because they're understanding the importance of their body. But
mm,
I wonder if there's a stronger way to say it. Because when I tell you that trauma is stored in your body, the underlying assumption is that that's bad. You have to release it from your body. You have to do something to get it out of your body. But that's not what the literature tells us is going on. Someone who's traumatized, if they're dissociating, they're disconnecting from their experience. They're disconnecting, they're dissociating. There's no association between who they think they are and who they are in their body. And this gets into the Bayesian brain, the brain as a predictor of what's going on, and the somatic experience of stress, and what we call allostatic load, and what Friston calls the free energy principle, which is related to stress. All these really cool things that have to do with we predict that this will happen, it doesn't happen, and so we have a massive stress response in our body. So, yes, trauma is in the body. Trauma is embodied. It happens in our body. But the process of healing from trauma is not to release it from our body as if it's a bad thing. The process of healing from trauma is integrating that experience and creating meaning from it,
mm.
making it meaningful, understanding it through a new lens, and then bringing forth and acting a new meaning in our body. So the exercise physiologist doesn't tell you to release the trauma. They might tell you to experience what your body's experiencing now and ask the question, what does that mean to you? And this is something that isn't actually embedded in the course, but it is in the course. Oh no, it is. Ooh, yes, it is. But I'll tell you it anyway. I've got a whole module on it. So if we have a person that comes to you with an experience, I like to ask the question, what are you feeling? And what does that mean to you? Then to ask the question, what else could that mean to you?
Mm.
right? So I've got this horrible feeling of my trauma in my body. Is it stored in my body? No. What's happening is your body's recreating that moment because you're stuck in that moment for a reason, for a really good protective reason. It served a purpose for you to be there. It's not stored in your body. It's a legitimate memory that your body has because it served a purpose to protect you at that time. And what we want to do is create a new meaning for you so that rather than releasing the trauma so it disappears from your body, you're losing a part of yourself then. You've been transformed by it. What we want to do is we want to find a way to bring that meaningfully with you into your future. So if I have an injury, I don't have to release the injury from my body. If I've injured my shoulder, we don't say, well, you've got to release the injury from it. It's trauma, but I'm not storing the trauma in my shoulder. What I'm doing is I've associated the experience of that injury with well-being or safety for whatever reason. And so I may be experiencing pain when I do an exercise involving that joint, but that doesn't mean that I'm re-traumatizing. It means that I might not have addressed the pain and paid attention to it and reintegrated it back into my life and created new meaning. Is this the pain of injury or is this some other pain? How can I recreate that? Do I need to feel that pain? Is there even an injury there anymore? Can I create a new meaning for myself from this experience? And and so and so trauma, I don't think is something we have to release from our body. I think it's something that we have to generate new meaning for and integrate that traumatic experience, give ourselves the capacity, the power of action, the mental level, and organismic energy. Give ourselves the ability to deal with it. And that's what exercise physiology does. We actually build up a person's physiological capacity to handle the trauma and to change our thinking around it. And what we do is we shift the chemical milieu inside the body. So a person feels traumatized. They're stuck in glucocorticoid land. They're stuck in running from a lion land. It's going to kill me. And so the body won't learn new things. The only thing it learns is danger is bad. And so exercise physiology has the tools to treat that part of the person's body so that they move from exercise is bad into I can learn higher order thinking. And
Mm.
and that's a physiological thing. We shift the physiological profile of the person's body so that they can learn higher order thoughts. They can integrate new meaning. But if they're stuck in the threat mode, they'll never shift from it. And so we can use exercise physiology through a number of really cool ways to do that. And that's the kind of stuff we unpack. I've just wandered in a big loop. I haven't gone direct to what you said because I get so impassioned about all the connections that this
It's,
brings.
but I think that just really highlights what we can do. Like I just
Yeah.
hear, sometimes I feel like the EP role is no one really knows how to explain what we do,
Yeah.
obviously, so many different
Yeah.
things because our scope is so big and varied across, conditions and what people obviously do and how they treat. But I feel like this is a really strong space that everyone's just like, oh, like we don't go there. We're not psychologists. We don't do any trauma work, or we just trauma informed and we know how to like handle clients that have
We're
been through
just
this.
trauma
But
informed.
like,
It's great.
well, it is, which we are.
It's very
But
important.
I feel like when you say it that way, it's like it's the cellular changes that happen because of the experience that affect someone's movement pattern, right? That we can then go, hey, we actually know how to do this. We just have to take all these different concepts, apply it together, and know how to do that. And I really feel like that just hits me when you say that. I'm like, oh, of
Yeah.
course. Like, why wouldn't we? It makes
Right.
sense. Yeah,
Right.
we're not like giving therapy. Like we're not talking through
No.
therapy like a
No.
psychologist at
No. No. No.
all. And I feel like sometimes I actually feel like we're in more of a dangerous space when we aren't trained properly because when people talk about their problems
Yes.
or their history, you kind of feel like you need to start talking back to them and oh
Yeah.
yeah, like and you go into this space of like, oh, I don't really know what to say. And what if I but then you're more inclined to probably say something that is actually more dangerous and like
Yeah.
therapy because you're
Yeah.
just trying to converse.
Yeah. 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 Absolutely. And that's part of the beauty of what we do. So we don't have to engage in talk therapy and counseling therapy with the client to help them. But
Mm,
we do have to understand some fundamentals. Most of us did first year psychology where we learned about operant conditioning and classical conditioning. Well, that's what trauma therapy is. It is just your operant conditioning en masse. Like you read the works of Joseph Ledoux, his book Anxious is really good, and he unpacks the molecular processes, the level at a cellular level, a molecular level, where we're having these associations being drawn up. And then you start reading the physiology literature of stress and allostatic load, and you start going, oh my gosh, like that's what we as EPs are dealing with every single day. We just haven't realized it yet.
mm,
And so if I'm shifting a person's body at a cellular level, all I need to do is create a meta narrative above that and explain why it's happening, how it's happening. And all of a sudden we're doing therapy with someone without having to go into the details of their story because you don't have to. We don't have to know that. We don't have to unpack all of that stuff.
mm.
But sometimes it's necessary. We have to listen to their story. I think that's
Yeah.
different. Listening to the story is different to giving therapy around the story.
Yes. And I think something that's also important to highlight here is you don't need to know every detail of their stories either. It's about how they're talking. Like, can you talk about, like, I feel like when you say we have to hear their story, people are thinking, oh, I don't want to sit there and ask them about what happened. Like,
Right.
if it's
Yeah,
right.
yeah,
So,
yeah,
like, we
yeah.
don't need to do that, right?
No, no. And we get really fearful of that. If you're comfortable doing that, you can do that. But no, we don't. We talk about emotionally, I talk about salience and valence in the course. We go
Mm,
a whole, that comes up a lot. And so, what is something that's salient to a person? That means what's important to them and and is that good or bad? That's the valence. Are we attracted to it or repelled by it? So we're now firmly in the world of the biological basis of emotion. Uh, Everything is salient to the being, and everything has valence. We either we either move toward it because we like it, we move away from it because we don't. As an EP, I can sit there and listen to a person and hear their story, and I can find the themes of salience and valence. Okay, I can hear, well, they like this, they don't like that. And I can say things like, well, what is it about that that you like? What is it about that that you don't like? Uh, why would you say that you like that? Why would you say that you don't like that? Do you want to do that? Do you not want to do that? In the process, what I'm doing is listening to their story. And so they feel validated. And I
mm,
haven't even engaged in the thinking behind what their trauma was. What I've done is I've engaged their experience as a person living in the world. And I've said, your experience is valid, it's legitimate, it's okay. And I don't have to know what's going on. I had a client earlier this year and I had no idea what was going on. And I just said something, I can't breach any of the details, but I'll make another story up. And, and what I said to them was, I had no idea of their story. I just met them. It was like a one-off session, 45 minutes we had together. And I just said something like, um, I got no idea what happened in your past, but you had nothing to do with it. I just want to affirm to you that you had nothing to do with it. No, I didn't. There was nothing. There was no indication to me that there was anything like there was no knowledge of them. It was completely out of context. But it just seemed like the right thing to say because of how they were. They seemed really timid and shy. And that's what I said. And then tears just started falling down their face. Okay. And so what did I do? I just said, it's okay. It's okay. What you're feeling right now is okay. And it's okay for you to feel it. And I said to them, I don't have to know the details and I don't need to know any of the details at all. You are okay and it's okay. And they just had a release and then their body got better. We did some stuff and we had some amazing change
mm,
occur because some people would say they'd released the trauma. The trauma was stored in their body. But that's not what had happened. What had happened was they hadn't been validated and given a safe space. And once they were validated and given a safe space, they were able to integrate that into their life. I didn't go into any details. 45 minutes. What do you do? I'm never going to see them. again, because of the context. Uh, and who knew that that's where it was going to go? No one. They certainly didn't. I didn't. But that's where it
Mm.
went.
And that's you listening to what they're talking about and understanding what's important to them. What?
All it is, what's important to you? What are your words telling me is important? How is your body responding in ways that tell me it's important?
Mm.
And we go into that in the course, that as an EP, I can sit there and attend to certain things in a person's body and certain ways of being that will tell me a truckload about them without me knowing any details. And
Yeah.
then I can address those issues purely from an exercise perspective. And then later down the track, we can say to them, you can apply this to your trauma if you want to.
Mm.
And it's at that point that they start getting gains in their psychological work. And so we're not taking away from their psychotherapy or their psychological work or their CBT or their ACT. We're not taking away from that. What we're doing is augmenting it. We're making it so that their body is immensely capable of making the changes that they're working through with their therapists. And that's what people don't understand. And what I want them to understand is that we are a linchpin to transformation. It doesn't work for everyone, but I tell you what, the number of people it works for, I mean, whew, it,
Yeah.
yeah, it's
I've
potent.
heard some pretty crazy stories from the work you do, like from client load, and it just blows my mind. Like those people that are stuck for years and years and years in their house, not leaving,
Yeah.
unable to do anything. And then you're
I have a client,
outside.
I've got
Go
permission to
on
share a
walking.
story. Yeah, she's got real complex, like I mean, ridiculously complex trauma stuff. Couldn't leave her home. And 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 over a period of months, she was able to address some of these concerns. And then at the same time, we're doing exercise strength. It's not just all, like it's combining everything. It's validating and doing exercise. And then was able to go overseas, which was pretty
Overseas from
unheard of.
not leaving your house.
Not being able to get up off the couch and move, uh, to being able to travel to another country altogether,
That is so
like
cool.
with such the complexity at play. Yeah, this stuff can really work. Yeah,
Yeah, wow. I can't wait to share it with people. What this is designed to be really practical, right? So we talk, I know there's a lot of mention about literature and theory in this, which is
yeah.
so important for the stuff that you do because you do really need that foundational learning. But what about the practical side? Like what are you most excited about in terms of sharing and delivering inside this when it comes to being like clinically practical?
What a great question. I'm just looking forward to people's minds being blown that they've got all these tools that they didn't realize they can use in this context. That's like one of the coolest things. And so, yeah, we unpack a lot of philosophy and theory. Like, there's a lot of time spent in the first session unpacking. It's
Mm.
pretty dense. Um,
It's dense.
right?
I was like,
Yeah,
oh man,
yeah.
this is
We
dense.
we and we have to move through it at pace. This is books worth of information that we're kind
Yeah.
of bringing out in a session. But we do that, and then we go, okay, how do we apply this? And then we spend the next 3 sessions going, remember this stuff? It applies like this. Remember this stuff? It applies like this. Remember this stuff? It applies like this. And so we take tools from a bunch of different arenas, and so I'm super excited about having people go, wow, I never thought about it that way, or I thought about it that way, but I thought about it that way, but I hadn't applied it in this way. And that's the thing I'm most excited about is the aha moments of clinicians going, oh my gosh, I can do that. Oh wow, I can do this. And giving clinicians hope. And that's what we deal in. We transact in hope, that's our currency. We give clients hope that they can manage their pain. We give them hope that life isn't going to be terrible forever like this. We give them hope that they'll be able to take the kids to school. We give them hope they'll be able to cook their meals, that they'll be able to sleep at night. This is what we deal in with our clients. I want to deal in that with other professionals. I want to give them hope that they can help their clients, hope that they can have tools to apply. And so that's what I'm looking forward to is 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 having those aha moments when the clinicians go, oh my gosh, I can do this. Oh my
Yeah.
gosh, you mean this is part of my scope of practice? Wow, I can apply it in this way. And I'm hoping that in our Q&A type sessions that what happens is the clinicians from their different worldviews say, could I apply this? Could I apply it to this context? And then unpacking that and saying, well, yeah, of course you can. Let's let's look at how. That's what I'm most excited about is just those aha moments and clinicians coming away feeling hopeful, feeling like, wow, I can sit with a client and I don't have to be scared that I'm going to re-traumatize them.
Mm.
Uh, I am equipped to make a difference just by doing this stuff in this way. Yeah.
I feel like it really helps advance your own professional skills in a sense that you get that workplace satisfaction or career satisfaction. There's so many EPs that I feel like they just don't have that depth of training to really do things that
Yeah.
are quite advanced like this, and maybe aren't satisfied in
Yes.
their career. And in reality, it's because they're not doing things like this or they don't know that they can do things like this.
Yeah.
And that's
Yeah.
something that I find that's so important for me. And I used to feel like that in the women's health space. Like, what am I really doing that's any different to a trainer? Like, now I've done the upskilling, I've done all the knowledge and I'm applying things. And I'm like, I would never be able to do this as a trainer. And I feel like a solid professional and a clinician, not a trainer. And it's like,
Mm.
that's where I think a lot of people are. And what this type of training does is help you elevate yourself so much that you're like, I'm actually really good at this and I'm
Yes.
loving my work and I'm really making a difference in people's lives and changing things that other clinicians haven't been able to do for this human in front of me. Right.
Yeah. 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 And isn't that one of the most exciting things?
Yeah.
Have someone come to you who'd had a problem for 12 years and 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 they're completely forlorn. They're completely feeling like nothing is going to work. And maybe it's the last thing, the last moment they're coming to. Another client earlier this year, she gave me permission to share, tell her story. And she came to me, that's the only story I'll tell, is one I've got permission to tell, because in this field with trauma work, especially, privacy is really important.
Mm.
And that's part of creating safety. And especially in women's health stuff, you're going to start, if you're dealing with stuff where there might be dissociation from trauma, we have to ask what kind of trauma is there? Where did that trauma come from and who did it come from? And for me as a male, and this is often domain of females, you see, where the trauma stuff, unless they're a psychiatrist, so many of the clinicians are female working in trauma world, which is fine and really important. So this means that as a male, well, what am I dealing with? So one client I had to, for months of working with them, I sat on the beanbag beneath them while they sat on the couch above me because of the history of trauma at the hands of males. So these are the kind of things we have to think about. But earlier this year, this other client, she came to a workshop I was running and um, overseas. I did some work earlier this year in Europe, delivering some of this content over there in Belgium to a bunch of physios and EPs and other practitioners and Pilates studio, and in Germany, in Czechia, Czech Republic, doing a whole bunch of cool stuff with trauma-based clients. And all the most of them were women. 98% of them. And this lady, she came, we did some stuff, that was all good, and she was engaging, and I had no idea what was going on in her brain. And she got some changes in her body, and that was lovely. And then she confided in me, and she said, when I came here, I had given up hope of anything, like completely given up hope. And this was the last straw. This is the last thing that I was going to try. Now, there were language barriers. I don't know what that meant. In Australia, we might think that that meant that there was ideation a certain way or whatever. I don't know, but the context for her was a bit different. But the key point of the story is that she was so bereft of hope. She didn't think that she could change anything. She didn't think that the things in her life that were so important to her, she thought she'd lost them all. And all I did was applied the principles of the first module, the first two modules, really, of this course with her. That's all I did. Then I applied exercise physiology afterwards. But this point when she told me the story, we hadn't got to the exercise side of things yet. Uh, we just applied the first two elements of the narrative assessments, the SVNA, and completely changed her life. Completely changed it. And she's now, I watch what she's doing. Um, yeah, we were able to we together created change. It wasn't me. It was her doing the work. It was her enacting what we did. And that's what part of the course is about, is teaching the clinician how to empower the client to make change so that they are the least dependent on you as quickly as they can possibly become that. They shouldn't be paying my mortgage. And I say that to clients, you shouldn't be coming to pay my mortgage. You shouldn't be seeing me so much that I get a lot of money from you. You should be
Mm.
becoming independent as soon as possible. Not necessarily a great way to become super rich, super quick.
No, terrible business model.
Certainly a great way to help people who don't have the money because the trauma has completely eradicated their capacity to live. Yeah.
Yeah, right. And that's a huge issue for a lot of people I hear is like the population that you want to help like that
Right.
know that it's a long term, potentially a long term commitment,
Long
and they're
term.
like, I can't afford to do this. But
Yeah.
if they get, if there's a little bit more training and you can teach this stuff and talk to clients or potential clients about the work you can do for them and get results or at least
Oh,
improvements in things initially that they're not going to be with you for the next 10 years,
yeah.
right, like
Yeah. Yeah.
that's
Yeah. Yeah.
helpful in itself, even having that knowledge to explain what we're
Yes,
doing.
that's right. The knowledge to say we can help you in this way and we can and you're not going to be coming to me forever. And the goal is to get you independent. And that's how a person with trauma gets better. So trauma is one of the areas of trauma is a loss of control, right? Your agency, your sense of control has been ripped away from you
Mm.
through no choice of your own. And so now we have compassion on them. Compassion is feeling, being moved for someone in a way um, that says you've experienced something that's not your fault, and I'm moved by that. So we have compassion on these people, and then our compassion drives us to help them become independent again. And what better way to help someone become independent than discovering that they can enjoy moving in their body?
Mm.
And so, as an EP, that's what we do, right? We help people find joy from moving in their body. We help people feel comfortable living in living with this physical body that they live with,
That
helping
is
them
so cool.
reassociate the parts of themselves through movement. Yeah.
Yeah. Oh, so great.
Exciting. So exciting.
It's really exciting. This I'm really, really, really pumped for people to sit through your program and learn all of this and hear the feedback around it because like I'm helping you. Like I wanted to bring this to life because everything I hear from you resonated so much for me and helped me with clients that I
Right.
think like more people need to know this. And I was like,
Yeah.
Stu, doing a course. Like I don't even care if you don't want to do it. You're doing it.
You will do the course.
We'll do this.
That's
um,
very much how, and
yeah,
that's very
it's
much how our
exactly
conversation.
how it went down. And then I'm like, this is the date.
The last 18 months or so.
Yeah. Um, I think the hardest part is actually trying to explain that what is it that we're going to be doing because it's such a different space. Like,
Yeah.
so I think there's a lot of that's come out already in this episode of the show that explains a lot about what you're going to be doing and the things we're covering, teaching. But if there is someone listening still right now that's like, oh, I'm just like, is this the right course for me? Like, are these clients for like I don't have complex clients like that, or like, what do you have to say in regard to that?
That's a really good question. That's a really good question. And I think people should be asking that question. That's the first thing I'd say. I'd say you're right to ask that question. It's a lot of money, it's a lot of time. Why should I do something? How is it applicable? And I would say this: every single human has emotions. When you engage with the person, you are always engaging with their emotions because it is with our feelings that we experience the world. Don't you want to give your clients the best experience that they can? And isn't the way to do that to understand how they have that experience and how you can manipulate the variables of physiology to bring about the best experience for your client?
Mm.
This is not about complexity, even though it's framed in terms of complexity in women's health. This is about humans and about us as a human engaging with a human and not being scared to do that. If you're scared of engaging with your own emotions, perhaps don't do it. Because to engage with another person's emotion is to be and to realize that you are an emotional being yourself. Unfortunately, every client you work with is an emotional being, and so you must be engaging with your emotions at some level every time you interact with someone. So, how about you become knowledgeable about your emotions and theirs? How about you become knowledgeable about how what you are feeling in your life and what they are feeling in your life is working together to create something beautiful? Because every engagement with every client occurs because of something in, emerging from the interaction. This podcast wouldn't exist if it weren't you and I bouncing off each other.
Mm,
If it was just you, yeah, it would exist, but it wouldn't emerge in the way it has because this is the two of us engaging together. In the same way that when the listeners are listening, what emerges from them is an experience where they're listening to you through their experience and they're creating meaning from the words that you say, and they take meaning and put it into their world and live it out. They act that meaning out in the world. And so I would say this is not about complexity. This is about working with humans and optimizing the experience of being human and being fulfilled within yourself so that you don't burn out, so that you can continue being fulfilled as a professional.
mm,
Because that's the other thing we cover is how do you pace yourself when you're working with the clients? Because it's really easy to burn out, really easy to become emotionally drained. And I've been there, and it's not a nice place to be. And so the course should all education in this arena, I think across our profession, should ensure that the professional doesn't burn themselves out, that they understand who they are and they understand their defined boundaries, which is again an active thing, that we're a unity. And but that two unities come together, structurally couple and create an emergent beauty. That happens with every client.
yeah. I
Mm.
also think like they've chosen to come and see you. So something is a struggle for them.
Mhm.
And this is important to them,
Yeah,
right?
and
Which is
yeah.
exactly what we talk about. Like,
You
you
bring that
know,
up all the time in all our conversations. That I think you bring that up every time. That this client has come to me, so there's a barrier
mm,
they want to deal with. They want a
yeah.
solution.
And we're in the space of healthcare, someone's health and function, and they're struggling with something, right?
Yeah,
So, um,
absolutely.
sometimes think that we forget that when we see people every day back to back. You know,
Yeah,
this is a job for us, but for them, it's actually a life-changing situation.
yeah, that's right. That's a really good insight, right? If you've got 6 or 8 clients in a day coming to see you, and you're doing the same thing, and
Yeah,
client in, client out. But if you're doing it well, then for that person, that's a moment in time when their life could pivot
yeah, exactly. So,
every day. It could be 8 hours, 8 clients a day, pivoting.
yep,
Yeah, we don't
yep.
even know it.
Well, I cannot wait to bring this to life.
Yeah.
It's almost coming so close. So by the time
Yeah,
this
not
goes
at
out,
all.
it'll be approaching very soon. But I'm excited. So thanks for jumping on today and sharing all that information. It's so helpful for everyone to hear what we're doing. And I can't wait to launch this.
Yeah, thanks for the opportunity, Courtney. I'm super excited about it. And I also look forward to people's feedback at the end of it, seeing how we can tweak it and,
Yeah, super important too.
more applied to what they do. Yeah, yeah.
It'll
So
be
thanks for
interesting.
having me. It's been great.
Very welcome. I will see you in the course.
You will. It's exciting.